are rolling in as we speak, but if with the permission of the chair and the speaker, we can at least start off the proceedings with the introductions, and then by the time Dr. Gautam Das starts his presentation, I'm sure we'll have many more people. Is it okay with you, Dr. Meena and Dr. Gautam Das?
Sure.
Lovely, great.
Sure.
Thank you very much, and good evening, everybody. Welcome back to a new edition of the D.Y. Patil Postgraduate Lecture Series. We've been conducting these series for the last 8-9 years now, and I'm proud to say that it just keeps getting better and better. And today we have another edition to take that legacy forward. We have the privilege of having Dr. Gautam Das with us. I will leave his introduction to Dr. Meena, but I'm just grateful to the both of them for having taken the time to be with us today. And it's my proud privilege to introduce to you Dr. Meena Sawant. I've known her for many years, and I think of her as a friend. She's a professor and the head of unit at the Department of Psychiatry at GS Medical College and KEM Hospital at Mumbai. She is a chairperson of the IPS Sexual Medicine Specialty Committee. She is the president of the Indian Psychiatric Society West Zone branch for the year of 2023 and 24. Child psychiatry, neuropsychiatry, and sexual medicine are her areas of interest. And she has over 30 years of clinical experience with more than 100 national and international publications, and she's published in more than 100 different magazines. She has been awarded at various forums, the Bhagwat Award, the PPI Award, the IK Munjaver Poster Award, the KSK Dubey Poster Award, the Dr. A.K. Nayak Award, as well as the Dr. L.P. Shah Award. I'm sure there are many more, but if I have to go through her list of accomplishments, I'll probably take away Dr. Gautam Das's time for the lecture. So welcome, Dr. Meena Sawant, and thank you very much for making the time to be a part of this. You have been with us in the past, and I'm glad to have you back. I'm sure you will continue to be a part of this academic endeavor going forward. I hand over the proceedings to you now, and I shall be back with you at the end of the talk. Over to you, Dr. Meena.
Thank you, Dr. Rashmin, and thank you for calling me once again here on the D.Y. Patil PG lecture series. We definitely have another interesting topic today, neuro-behavioral medicine. Is there a need for a new paradigm of clinical psychiatry? Well, we've grown learning psychiatry and understanding it as a complex interplay between biological, psychological, and social factors. A neurobehavioral approach can definitely help us understand these interactions better and probably tailor interventions accordingly. So, though the field of clinical psychiatry has definitely improved over and evolved over these last 3 decades, where we have defined and refined diagnostic criteria, we have looked at newer treatment approaches, and we are trying to understand the neurobiological mechanisms of most of the psychiatric conditions. And neuroscience itself has evolved so much with lots of advancement in neuroimaging and molecular genetics. So definitely, I would say that today there are lots of opportunities for identifying biomarkers, and probably which will help us in developing targeted interventions. So integrating all these factors in clinical practice is the skill that we have to learn, and who better than our expert today. So let me introduce to you all our speaker for the day, Professor Gauthamadas UDIPI. He is a psychiatrist with over 3 decades of experience, and he retired as professor and head of department at MAP Institute of Medical Sciences and Research, Melmaruvattur. He has received 1 international award, 2 national, 2 state, and other awards in recognition of his work. He has done pioneering work in the field of disaster mental health. He has published 3 books and a chapter on neurobehavioral medicine in a textbook of medicine. He is an excellent resource person at most conferences, also in WHO, and he has also served as an associate faculty of the British Open University, UK, for the last 7 years. So without much ado, I invite our expert, Professor Gauthamadas, to please take us on this journey.
Thank
Over
you.
to you, sir.
Thank you, Dr. Ashmin. Thank you, Dr. Neena. I thank the D.Y. Patil University and the D.Y. Patil series and Dr. Ashmin Kolera for giving me this opportunity to be here today. And thanks to Dr. Neena Sawant for a rather flattering introduction. I don't know whether I qualify as an expert. So let me start sharing my screen. So can you see the screen?
Yes, sir.
Yeah. Okay. So the topic neurobehavioral medicine, is there a need for a new paradigm of psychiatry? When I asked Dr. Rashmin whether I should stick to this topic, he said, please do, because it is intriguing. Why is the screen not moving? Okay, there is a Chinese saying that when the student is ready, the teacher appears. Now, as I said, I'm not an expert here. Neither am I, do I consider myself a teacher. Because a teacher is a person who communicates with you, and that communication can be flawed. And it depends on the ability of the person who is delivering the communication and the ability of the person who is receiving it. So the only purpose of the outer guru is to lead the inner guru. By that I mean that only if and when you are ready to unlearn things will you be able to learn new things. And that is the meaning of this saying. And this is something that I have been telling all my students, because before you can learn new things, you have to unlearn a lot of things that you have already learned and which are ingrained in whatever you're doing today. So I would like to take a different view here today. This, as you can see, is Arc de Triomphe in France. And this is a very, very close-up view that we have. And that is what psychiatric practice today is turning out to be. It's a very, very close-up view of the brain and the mind. And sometimes it can get to be a rather narrow view through the little archway there into just the mind. So the question is, should we continue with this rather zoomed in approach, or should we have this kind of an approach to psychiatry? And today, I am going to take this bird's eye view. Now, there are a lot of challenges here because the subject is vast. There's a huge amount of research that has been done. There are a large number of concepts that we have to take into consideration. Many, many convergent and divergent theories, which can get quite confusing. There are a lot of path-breaking findings that go totally against the grain of tradition, and a massive amount of data that has to be sifted through. Now, very few people can do this. Each topic by itself, probably every slide that I put up today, is a workshop by itself. So I'm going to try to take a bird's eye view, which can be quite challenging because simplifying such a complex task is humongous. But I will try to make an attempt. Now, what is the common thread through all the frameworks that psychiatry has been through over the last 100 to 150 years. We have the psychoanalytic frameworks, the psychodynamic frameworks, mind-body stress medicine, consultation liaison psychiatry, psychosomatic medicine, biopsychosocial constructs, neuropsychoimmunology, and behavioral medicine, and a whole lot of other things in between, as you can see in the graphic over there. Now, I would like to start with the interesting concept of behavioral medicine, which was proposed at the 1977 Yale Conference of Behavioral Medicine. But somewhere along the way, this construct got lost. So neurobehavioral medicine is a field concerned with the development of behavioral science knowledge and techniques relevant to the understanding of physical health and illness, and the application of this knowledge and these techniques to prevention, diagnosis, treatment, and rehabilitation. Now, this is a very, very interesting construct that was proposed. But there was a huge debate on this. There were many people who said behavioral medicine is identical to psychosomatic medicine, that behavioral medicine is only a fraction of psychosomatic medicine, that behavioral medicine is nothing but psychosomatic medicine in a new form. And the challenge there was that most of the constructs of the behavioral medicine approach that was proposed tried to fit psychiatry only in so far, the mental health and mental disorders, only so far as they contributed to physical disorders as an endpoint. So coming back now, what are the common threads that run through every one of these constructs? Now, if this had been a physical meeting, I would probably have asked you to answer this question. But since this is a webinar, I will move on here. The common thread are the regulatory systems of the body. We have the emotional regulatory systems. We have the neural regulatory systems. We have the endocrine systems. We have the immune systems. And then we have the molecular, genetic, and cognitive systems. Now, how much of this do you study during your MBBS and MD? Because it is only based on this that your knowledge of neurobehavioral medicine as a psychiatric construct can develop. And all these regulatory systems are controlled by developmental systems. So let's zoom in a little further and look at the developmental systems that control the regulatory system. It starts way back from preconception to maternal health. So psychiatry as a subject, as a field, mental health as a construct starts right from maternal history. And that is linked again to perinatal development, infant development, biological neurodevelopment, which is all linked to maternal mental disorders. It is related to birth. It is related to emotional regulation of the mother as well as the child. And it also involves attachment of the parents to the child and how that controls the developmental systems. Now, if you zoom further in, you find that we don't stop there. We don't stop at maternal health. We have to go way back into evolutionary genetics. So evolutionary genetics have a major role to play when it comes to regulating developmental systems. Humans have evolved over time. So based on the region in which you have evolved, disease genes, viral infections, environmental toxins all have a role to play, as do neural development, susceptibility of every single small effect that is there during the evolutionary development. All these have a role to play on how the fetal brain develops, how the fetal nervous system develops, and that controls the behavioral responses. So brain-based endophenotypes are complex functional interactions and emergent phenomena that lead to mental disorders. And on the outer envelope of all this are the socio-cultural factors like religion, language, and so on. So we have genetic systems, we have epigenetic systems, both of which are influenced by the environment to give rise to physical and mental disorders. So everything revolves around gene expression. So gene expression is controlled by psychological and physical experience and also the hormones, metabolites, and proteins in the body, as we shall see. So epigenetics is a very, very relevant topic here. Epigenetics control how the genes are expressed. So genetics and epigenetics go hand in hand. There is no genetics without epigenetics, and there is no epigenetics without genetics. Every single environmental fact, both the internal environment as well as external environment, switch the genes on and off through various regulatory systems. And this slide here gives you the whole thing in a nutshell. Now, we shall not go into the details of this because then again, that's a workshop by itself. So from genotype through chromatin, the phenotype evolves. So you have environment interacting with the gene, environment interacting with the epigenome, and all of which interact with each other to give us the endophenotype of the disease. So involved in this process of genetics and epigenetics are the transcriptomics. The way the DNA is transcribed into the RNA, which then forms the proteins. Our body is nothing but a mass of proteins. Our brain is a mass of proteins. So how these proteins are transcribed relate very much to what kind of brain development occurs. What are the changes that occur in the brain and how behavior is expressed. Going deeper down, drilling down, we come to proteomics. The genome consists of 20,000 plus estimated genes, but the proteome consists of 6 million estimated proteins. So you can see the massive task we have here of trying to understand how behavior is expressed. It is so complex, and I don't know whether one person can actually grasp the magnitude of this, but we can try. And then, of course, we have not only the proteins, but also all the other metabolites that form the cells of the body. So metabolomics have a major role to play in the way the body, brain, and behavior are controlled and regulated. So if you look at it, our behavior is expressed through the building blocks of genomics, transcriptomics, proteomics, and metabolomics. So the genome gives rise to the phenotype. And the phenotype is what determines behavior and behavioral disorders. Now, why is this important? For many years, we have been talking of comorbidity. We have been talking of disorders which occur together, mental disorders which occur together with physical disorders. Taking, for example, the autism spectrum disorders. We know very well that they co-occur with seizures, epilepsy, GI impairment, the HPA axis dysfunction, immunity issues, methylation issues, metabolic problems, motor dysfunctions, and a whole host of other things, which is why we call it the spectrum, the autism spectrum. We also know that a whole lot of psychiatric disorders coexist with cardiovascular disorders, thyroid dysfunctions, obesities, pain disorders, metabolic syndrome, diabetes, and a lot of other physical disorders. Now the question is, are we talking here of a comorbidity? Comorbidity means that they are occurring together without any relationship that we can display. Or are we dealing with a single morbidity? Before we progress further along that line, let us look at another aspect of how behavior is controlled. Homeostasis is it's the basis of how the balance of the brain is maintained. I won't go into the details again of homeostasis, which again is a huge topic by itself. So we can see that there are primary outcomes and secondary outcomes of homeostasis. So we have allostasis. So when the burden of stress increases, it gives rise to, at the molecular level, mitochondrial changes, which give rise to cellular dysfunction, which give rise to organ system dysfunction. Now, are these different for the brain and the body? Are these different for the mind or the physique? No, because it's the same body, the same genes, the same mitochondria, which are there throughout the body and the brain. So we are dealing with one systemic homeostatic regulatory system. And when anything goes wrong here, it is reflected throughout the body. So when there is exposure to stressors, there are functional network alterations that are made, which result in cognitive and attentional dysfunctions, which then result in the clinical symptoms that we see of mood, sleep disturbance, motivational issues, fatigue, rumination, and so on and so forth. So all these are on a basis of predisposing factors. So when the stress overloads, there is a disruption of homeostasis, which gives rise to the symptoms. And I say, I'm fond of calling this the stabilizer in the brain, the voltage stabilizer in the brain. So when the voltage stabilizer gets disrupted, we get various clinical symptoms. Now, what controls this voltage stabilizer? There are two concepts that we have to look at here. One is vulnerability. Vulnerability are factors which reduce the body's ability to maintain homeostatic balance and which reduce the brain's capacity to handle the allostatically. And at a genetic level, these mutations or chromosomal alterations give rise to specific situations or loss of survival of the organism. And at the epigenetic level, these are the chromosomal changes which occur, and subsequent level gives rise to organizational disorder. So vulnerability, again, is genetic. We have also the opposite, which is resilience. Now, while vulnerability factors have been predominantly identified, resilience factors are not yet very clearly identified. So these are factors which let the body handle the homeostatic balance better. And at the genetic level, these are mutations and chromosomal changes which endow the organism with increased functionality. And again, at the epigenetic level, these are genetics in these are changes in genetic expression, which then result in molecular changes, which are then expressed as a resilience of the organism to stress. So putting all this together, we can see that we have the genome, the genetics, the epigenetics, the proteomics, the metabolomics, all of which are concerned with resilience and vulnerability. And when combined with stressors like traumatic life events, negative life experiences, disadvantages, cultural changes, they give rise to the diathesis, which is the changes in the genetic factors and biological characteristics and the psychological traits. So this is how stress diathesis occurs. So once again, coming back to comorbidities, we have the, as we talked about, the genome, the proteome, and the interactome. So the genome, epigenome, proteome, metabolome, and connectome interact with each other. And the gene-protein interaction is very interesting. Different proteins interact with genes at different nodes. And these nodes are interconnected. And these connections are known as hubs. And edges are the zone of interaction between genes and proteins. So the gene-protein interaction gives rise to a host of diseases, of which neurobehavioral disorders are only a portion. So we have heart diseases, we have diabetes, we have cancer, we have metabolic syndrome, we have rare diseases, we have inflammatory diseases, we have immune system disorders, all of which co-occur with neurobehavioral disorders because they are one and the same expression that we are seeing. They are not distinct, succinct, independent entities. but just one whole canvas that is being painted. So the task that we have is to identify these interactomes as networks within which network patterns and relevant connection paths have to be associated with diseases which can be identified. So you can see what a task there is that we have ahead of us in order to translate all these theoretical factors, research that has been done into clinical practice. So neurobehavioral medicine is a result of a co-evolution of hierarchical layers of different networks: genetic, transcriptomic, proteomic, metabolic, immune, neurovascular, cognitive, and only then the social networks. Now this whole, when we talk of social networks, we are talking of the outer world. And how is the outer world interpreted by the brain? Here we have to understand the concept of cell signal. How every single neuron is a transducer. Transducer is one which changes one form of energy into another form of energy. So take, for example, vision. Light enters the eye. The retinal cells transform that light, the light waves, into electrical signals. These electrical signals are transformed into chemical signals. These chemical signals are transformed into images in the brain. So it is not as simple as taking a photo, because these signals are all neutral. They are just changes in waves. They are these changes in electrical covalence of the cells. They are changes in proteins. They are changes in metabolites. So how on earth does the brain convert all these into thoughts, images, emotions, behavior? It is a miracle of cell signal. Cell signaling is the way the world is interpreted by the brain through various signals, and the way the brain responds to the outside worlds. So the cells interact with the environment. The receptors are comprised of extracellular and intracellular domains. The extracellular domain relays information about the outer world to the intracellular domain. The intracellular domain then interacts with the intracellular signaling proteins, and these intracellular signaling proteins further relay the messages to the effector proteins, and the effector proteins mediate the appropriate response. So we have neurobehavioral disorders which have a bottom-up approach, which we have just seen, that is from the genome up to the metabolome. And then there is also a top-down approach, from the brain to the circuits, to the cells, to the synapse and the organelle. So now let us start from the top. Neurons are organized into circuits. So nearby neurons are connected together to form nodes or short connections. Neurons farther away are connected through what are called hubs. And then there are neurons very far away in the brain and the body, which are connected through what are known as small world networks. So we have the nodes, which are a group of neurons close together, hubs, which are groups of nodes which are connected at long distances, and then you have the small world networks, which are groups of hubs which are all over the brain and the body. So hubs form rich clubs, and we have various hub nodes and hubs. And then we have layers of neural connections, which are known as modules. So modules are from different layers. So you have the networks, and then you have the modules. And then you have, at a macro level, the various tracks which we study in our anatomy and when we do our MBBS. So the regional circuit tracks between the various areas of the brain. So again, these neuronal circuits are at three levels. At the macro scale, the tracks. At the meso scale or the mid scale, the modules. And at the micro scale, the hubs, nodes, and small world circuits. Now, all this circuit architecture has been widely studied, and various circuit biotypes have been identified. So circuits have been identified for self-reflection, salience perception, conflict detection, attention, negative affect, positive affect, cognitive control, environmental adaptation, social consideration, behavioral control, as well as sensory motor, visual, and auditory function, which we study right from. All these circuits are integrated with each other to give rise to brain function, emotions, cognition, and behavior. So we have functional neural circuits, which, when disordered, gives rise to dysfunctional neural circuit biotypes, which have been identified. Now, if you look at these dysfunctional neural circuit biotypes, you will very clearly see what you're dealing with on a day-to-day basis in your clinic. You have biotypes for rumination, conflict detection, inattention, anxious avoidance, negative affect, threat dysregulation, negative bias, positive affect, anhedonia, context insensitivity, cognitive discontrol, maladaptive perseveration, aggression, social disregard, inflexibility, impulsive compulsion, which goes way beyond any ICD or DSM terminology. So this is what we meet with in clinical practice. And this is what we deal with on a day-to-day basis in the patient. Now, this has very little to do with many of the ICD and DSM taxonomies that we use today. So in order to be able to clinically manage patients, we have to identify the neural circuit biotypes that are being disordered and then try to correct the neural circuits in order to correct the disorder. Now, once again, all this goes back to brain development, which starts in the fetus, the neurogenesis, neural migration, and it doesn't stop there. There is apoptosis, which is the proliferations of neurons which occur from birth to adolescence. There is a pruning of these neurons, which is apoptosis. So too many neurons is also not too good. So you have to have the optimal number of neurons So the neurons have to be pruned, and apoptosis is a very, very important process. And very often, many of the disorders that we see in our clinical practice are due to inappropriate apoptosis, inappropriate synaptogenesis, inappropriate gliogenesis, and disorders of myelination and experience-dependent synaptic pruning. So once again, we come back to factors which are not covered by the clinical taxonomies that we use today. So putting the whole thing together, if you have a patient who's coming with binge intoxication, you may find that there is a problem with circuits of affect, circuit of emotional discontrol, circuit of impulsion and compulsion, and problem with preoccupation, anticipation circuits. Now, all of these come from, as we said, the development, the genes, the proteomes, the metabolomes, and the gene-environment interactions, and the various omic interactions, neural development, all of which affect the incentive salience in the person, the executive function in the person, and the reward deficit and self-hate deficit, and all of which have to be brought under control if you are going to treat this person with what presents as binge intoxication. So, the overall picture is one of mental health and systemic inflammation being extensions of each other, with stress diatheses coming in through lifestyle, biological factors contributing through gene variants, epigenetics, metabolomics, transcriptomics, and all that, all of which are controlled by resilience, vulnerability, and healthy development. So the question that we are left with is, are psychiatrists dealing with disorders of the mind only, disorders of the brain only, or disorders of the body? So there's a very, very interesting paper that was published, I think somewhere in 2022 or 2021, which concludes that schizophrenia is not a brain disorder. Schizophrenia is not a unitary disease. DSM and ICD are not the gold standard to diagnose schizophrenia. Schizophrenia is not comprised of positive, negative symptoms only. It goes way beyond that to disorders in the body. Schizophrenia has no distinct cognitive impairments. And schizophrenia is not a dementing or neuroprogressive disorder. So this is a lot of food for thought. So the current situation is that in psychiatry today, advances in neuroscience have not been incorporated into clinically meaningful taxonomies. Training programs do not provide psychiatrists with adequate training in neuroscientific advances. And practitioners do not have enough neuroscience-based tools to inform their clinical decision-making. So the way forward is the development and adoption of a neuroscience-based behavioral medicine taxonomy, which is suited to clinical actions in a way that addresses the gap between neuroscience advances and clinical psychiatry practice. So the holy grail of psychiatry that we are heading towards, probably much, much faster than we think it is possible. Maybe within the next 10 years, maybe within the next 20 years, at the way neuroscience is progressing, we have the holy grail of personalized psychiatry, where you can do genomic testing to figure out where exactly the problem lies, which medication is suited to which person. And we may even have access to genetic engineering, which could transform psychiatry into preventive medical science. Thank you. I hope that that was not an overload on your brain.
Thank you so much, sir. An excellent talk, very clear, lucid. And yes, you definitely made it simple to understand for us novices who are trying to understand genetics, epigenetics, genomics, metabolomes, difficult to pronounce also. And I am sure at least the PGs got sensitized to understanding what is there in neurobehavioral science. And though we have, one chapter on genetics, one chapter on epigenetics, one chapter on neural circuits, we still have to progress further and learn how we can translate it into clinical practice. As you're saying, tools will come up and maybe there will be precision psychiatry, say over in maybe 5 years from now, we are looking at changes coming up. But our curriculum still hasn't changed. So somewhere there is a big lag or a gap between the two. So if for precision psychiatry to come up, I think somewhere the study of genetics or epigenetics has to be inculcated from our school years so that some foundation is there as we take it ahead. Then excellent. Now I asked for questions, but I can't anything in the chat as of now. But suppose if, like you talked about the dysfunctioning neurocircuit biotypes, and you mentioned a few things where we could, kind of pick up those and whether we need to look at that rather than look at taxonomy and try to fit them into a diagnostic cluster. So for a usual PG, what are the skills you would like them to inculcate for understanding neurobehavioral medicine? If you could just tell what they should focus on or what they should look at.
I am very fond of telling my students that a psychiatrist is first and foremost a physician. Second, he or she is a neurologist, and only then a psychiatrist. So it is very, very important that you have a very strong base of internal medicine.
So that's excellent, sir, because we do find that there are so many medical colleges which have cropped up, and newer colleges. I'm sorry, I'm not. So your voice is cracking.
Yeah,
yes, sir. Please continue.
We're not getting the voice feed.
Nina, I think your voice is cracking. Maybe you need to switch the video off and just keep the audio on. Maybe
My voice is not there.
No,
Hello?
it's cracking in between.
Hello? Hello?
Yeah, we can hear you, but your voice cracked. So you can probably turn off your video.
Okay, one second. Yes. Yes, sir. Yes, sir. I was asking you to continue. I'm sorry, I missed out. You had spoken about being being training in neurology, being a physician. I caught only that much.
Yeah, that's the base of it. You first have to have a very strong grounding in in internal medicine, because what we are dealing with is a body system. So brain is part of the body, so it does not function in isolation. So we have to understand the entire body system, which means a very good grasp of internal medicine and neurology as a part of it, and not just the neurology that is being taught in MBBS, but you have to go beyond it to neuroscience and understand the concepts that we talked about. And only then can we try to correlate, say the circuit biotypes with clinical practice outcomes. So I think when I talked of the circuit biotypes, it's a very interesting concept, though it's still in the nascent stage. The circuit biotypes which have been identified are very, very clinically relevant. And how the circuit biotype changes occur from a genetic and epigenetic model comes from a proper history. So history taking is a skill which is dying out today in medicine as well as psychiatry. I always, another favorite saying of mine to my students is, diagnosis is based first on history, second on history, and last on history. And everything else only corroborates whatever you have diagnosed through a proper detailed history taking, which starts right from family history, the genetic tree, developing a family tree, the disorders within the family. And you will find that in a patient with psychosis or a patient with depression, very often you have a strong history of alcohol abuse, you have history of cancers, you have history of cardiovascular disorders, you have history of strokes, all of which are pointers that this is a pathology which is going to affect the brain and the behavior. And then you need a very strong maternal history, proper history of birth, and a proper history of the environmental influences that have contributed as the child develops. So a very good history-taking skill is what is required. And it is not only a science, but also an art, because ultimately you will have to be able to take this history within 5 minutes in your clinic. You don't have 2 hours, 3 hours, 5 hours like in the West, where you sit with a patient for a whole day. Probably in the UK, a psychiatrist may see 5 patients a day. Whereas here, we see many, many more patients on a daily basis. So we'll have to develop the art of history taking and clinical correlations, along with, now, of course, you can use, the internet AI-based skills to quickly try to correlate your history with the lab findings and with the imaging findings, and try to come out with, outcomes that you're looking for.
Thank you, sir. I think that was a very important point that you reiterated about history-taking skills, and these are the basic skills which we expect our students and PGs to master, along with the communication skills. And as you said about the deductive and reasoning skills, which would come if they have taken a proper history and if they have understood the basics, and then they can clinically correlate and of course do a systemic correlation too, to help and get better patient outcomes. So overall, an excellent talk, sir, and I'm sure our PGs today have benefited from the same. I cannot see any questions as of now, so I consider that they have understood whatever you have spoken today, and maybe we can go over to Rashmin.
Right. Fantastic. I'm suitably impressed how Dr. Gautam Das has managed to simplify a very complex perspective and make it so interesting, so palatable, yet so much more inviting to want to come back to it again and again is really inspiring. And in that sense, this is a very holistic approach towards psychiatry as a subject and towards clinical medicine as a whole. And though as far removed as psychology might be from the topic at hand today, but it's so accurate, a juxtaposition of Gestalt's principle, which says that the whole is always more than the sum of its parts. So he's managed to put it all together so well, and it's really very thought-provoking. And I'm sure our PGs are going to be really inspired by this talk today. So thank you very much, Dr. Gautam Das, for that excellent presentation. Now you've got us hooked on, so we are going to have to call you back for many more encores to this session today. So thank you very much for taking the time, and thank you, Dr. Nina, for being here and inspiring our young PGs with your mentorship. And I, of course, thank all the audience who have been a part of this session today. There were many senior consultants who joined us as well. So clearly, Dr. Gautam Das is more popular than he thinks he is. And I'm sure we will have more and more of you back at our future sessions. Of course, thank you to Dr. Sun Pharma for its unflinching support. And I wish you all a great evening ahead. And thank you once again, Dr. Nina Sawant and Dr. Gautam Das.
Thank you, Dr. Ashwin and Nina, and all the PGs who attended.
Thank you very much.
Thank you,
have a great
everybody,
evening
and goodbye. Yes, thank you. Bye-bye.
Thank you. Thank you so much. Bye.